So this is, okay, so this is a middle-aged person and presents with a no history of liver disease, just presents with abdominal pain and kind of has this mass, not a subtle finding, very heterogeneous, kind of peripheral enhancement. Like,
and you're saying no history of liver disease, but I feel like the background liver looks a little abnormal, like it looks a little nodular there.
Yeah, well, but I'm not sure, right? I mean, here, I think part of it is, there's distortion by this mass. So I'm not sure you ever, like, if you go up, right, that looks pretty normal. The patient doesn't have documented history of
Okay.
disease. So no Hep B, no cirrhosis, no nothing. Okay, so so this huge mass, right, central liver, kind of heterogeneously enhancing, mostly in periphery. You can see kind of, the evil gray of tumor, as Aarti likes to say, diffusion restriction. So, and you can see that on diffusion has that, the periphery also kind of, is hyper intense more than the central. So again, that has that target-like appearance. Just for the sake of kind of, kind of nice companion, you can see that obviously the features are unchanged just because we go from one modality to another. And you can see that. Anyway, so, so obviously this is malignancy, right? And, with this appearance, you just have to provide differential and send the patient for, for what do you call it? For biopsy, and they did. Anybody has any? I mean, this is like,
I feel like we always say cholangio, and then like whenever you say cholangio, you have to think about Mets, although this looks solitary, but rarer things like a neuroendocrine also could be possible.
Right. Why does it keep coming back? I keep turning off the dates and stuff, and it just keep coming back. Anyway, so this was biopsied, and this is sarcomatoid carcinoma. I think I've seen one case of this before in my life. So it's just like a really aggressive neoplasm.
When you say sarcomatoid carcinoma,
That's
it. Like there's is it adenocarcinoma or
sarcomatoid carcinoma? That's the pathology report.
Okay. Is it primary liver or presumably primary, right?
Primary, yeah.
Wow.
I think it's the same thing as carcinosarcoma, of which I have one case in patient with cirrhosis. Pretty right. So it's like a really aggressive subtype.
Yeah, this is the type you're never going to call it.
No. But this is something like you can recognize this is a malignancy and B aggressive one, right? So whenever you see like central necrosis and curve, like target-like appearance, and that's not going to bode well usually the patient. Although the patient's doing okay, she had I'm not sure, resected and wait, she have resected?
I was going to say,
I don't remember if she had resected.
Extended left or something?
Say it again.
Did they do like an extended left hepatectomy to like it would be hard to resect this?
Yeah, let me I'm gonna start sharing just so I can see what the most recent CT looks like, which I think that this is the one that I read. And I just can't remember what happened. So as of June of this year, so but no, they didn't. They could not resect it. I think they're doing some, let's see.
Maybe like chemo radiation.
Yeah. There's no local regional thing, nothing. It's just kind of. Oh, you know what? I forgot to show you an interesting finding. Let me just make it remove the annotations. Okay, hold on. You can see it actually goes into the IVC, suprahepatic IVC.
Can you scroll down from there?
We see the post
Oh,
phase.
yeah, I don't see it.
Oh, I'm so sorry. I keep forgetting that. Like if I stride anyway, it doesn't matter. But here we go.
Hmm. Yeah, even just that makes it unresectable, probably because
Right.
it's involving all the.
But I want to see if I can here's the most recent CT. You can actually see it nicer. The tumor just kind of goes up and right into this thing.
Wow.
Yeah, pretty crazy, huh?
Okay, Nelly, you're up.
Okay. This is a patient that came in with right flank pain. So we got a non-contrast CT. These are the lung bases. No priors. And then there's no stone. They're looking for stones, but there's no stones. Patient had prior Roux-en-Y gastric bypass. So what do you guys think about this lung findings?
Obviously not dependent changes.
Here, let me give you the.
I would have maybe brought up aspiration, given like dependent, patchy. I don't know.
Would you recommend anything or?
I'd probably call my chest colleagues.
Yeah,
I have no shame in calling for help. Chest, MSK, neuro.
no, that's a great idea. So to me, I thought this looked like a bubbly appearance, like lung consolidation. So I reckon, and I was worried about PE. So I recommended a CTPE protocol. And this is what the CTPE protocol showed. Huge amount of clots.
Wow. In retrospect on yours, could you see some of the clot down there?
Let's check. I didn't appreciate it at the time, but let's check.
Oh, it's a non-tumor, I see.
Yeah, they were looking for stones,
Yeah,
flank pain.
yeah. Good call,
So,
Nelly.
yeah, no, thanks to my cardiothoracic attending Rob Sue, who like taught me this when I was a first year resident. And he's like, this is the bubbly consolidations of PE. So I couldn't find a radiographics paper, so this is what pulled up. And so this is what it looks like, and this is what we see with PE, pulmonary infarcts. These are more obvious examples of it, but what the case that I showed was more kind of subtle appearance. But
Nelly, the case you showed, like this one is kind of more triangular. The case you showed looked to me more like layering, but is that true? Like infarcts are generally a little bit more triangular.
I think they eventually become triangular. I think mine was still acute, so it hadn't become triangular yet. Maybe. I mean, I'm sure there's a time component to it, and the changes that manifest with time. So anyways, there's a bubbly appearance that you can see with PE. And so with this case, I thought that's what we were beginning to start to see, these little bubbly appearance right there. So anyways, just for us to be
Tell me
aware of.
again, what do you mean by bubbly? This to me looks like patchy ground glass. I don't know. I don't understand what you mean by bubbly.
Like right there, these little.
Oh, as if there's like little bubbles.
Yeah.
Got
Yeah.
it. Okay.
I don't know if that helps or not, but like within it.
It does help. Thank you.
Okay.
Okay, so this is a pancreatic cancer patient. You can see here. This was a CT, and anything exciting other than the cancer?
There's some like nodular stuff in the soft tissues. Oh, I guess that's
Where the IVC looks. Oh no, never mind.
And then
fine.
they've got like air fluid levels in their colon.
Right. Right. So I'll tell you, it was read as like, you know, the head mass, I believe it was unchanged, and there was steatosis, and that's it. And so the patient came back 6 days later for liver MR. You can see here that there are quite a number of lesions, even on T2, right, with that evil gray of tumor. You can see them nicely on T1. Right, so anything, so hepatocellular lesions can be ISO on T1, but metastases generally are going to be hypo. So if you don't have the hepatobiliary phase, at least peruse the pre-contrast always.
The other thing that I was thinking about was abscesses, like patients who have obstructive, like malignant obstructive cholangiopathy can kind of get abscesses. But here we see more rim
That's true,
enhancement.
that there's no bill deal here, and the patient wasn't sick. You can see that. It's true, you can't often tell, you know, cancer, between cancer and abscesses, but you can see that, but you can see how many of the abscesses, I'm sorry, of the metastases that are here. When you go back, right, and look at the CT, you can probably appreciate, right, like
Ooh, this is great. It's the like perfusion abnormality, because basically those Mets are
Right.
taking out the small portal vein venules, and you've got the hepatic arterial buffer response. So yeah, if you see perfusion abnormalities in a patient with like suspected Mets, that should make you more concerned.
Right. Well, the problem is, I forget, he or she, the patient also has pretty significant steatosis, right? And so you can see this heterogeneity from steatosis. So in retrospect, you can see that this is a little buildup, which we actually see on MR as well. Right, you can see here, right there, right? And it's caused right by this little Met right there. So, and you know, patient does have steatosis in an out of phase, although probably not as bad as you would think from CT, but it's there. Anyway, so it's just another one of those, you know.
Victoria, what's the time difference between these two?
6 days.
Wow.
7 days, I'm lying, 7 days, 7 days. Yeah, this is like, I have a few of these, and every time this happens, I get like really terrified of how easy it is to miss something on routine, you know, on routine CT.
This is why
Sorry,
like
can you
imaging just
show
needs to
the
get cheaper, so that every patient with pancreatic adenocarcinoma has a staging multiphasic CT and an MR for their liver and others.
Right. This wasn't even staging. Patient, by the way, patient had a MR 6 months ago and was normal. So these are all new Mets. But
can you show me the coronal for the CT?
okay, let me stop sharing, just because sometimes it de-anonymizes the patient when I do this. So give me a second. Let me re-anonymize it and reshare it. I mean, knowing that they're Mets, right, you can sort of go back and say, okay, it's quite heterogeneous, and some of these things are a little bit hypo, but there's no way to, you know, to kind of do it prospectively. It's all attributable. It's all.
MR wins again.
Huh?
I said MR wins again.
I know, right? Every time these cases come through, I'm like, Jesus, it's scary.
There's a paper that was published in Radiology that looks at conspicuity of liver metastasis study. Let me share the paper with you.
Okay.
And sort of search pattern, like things that we can do to improve our conspicuity of liver metastasis. So this paper was published this year. It was it won the SAR kind of like, is it the Morton Award or the All Around Scientific Presentation Award?
Yeah.
In 2022. So what what they did was there's multiple papers that came out of this study. This is one of them. And like they looked at variability in detecting liver metastasis. Number one, by specialists versus general radiologists, and number two, by the type of metastasis that was missed. So the take-home message is, number one, that specialists they detected more liver metastasis, but the metastases that they picked up were along the periphery. More the ones that general radiologists missed were the ones that were along the periphery, along the margins. Centrally located livers metastases were picked up equally by both specialists and general radiologists. The other thing that they showed was search patterns. So the way the key search pattern that we needed to do to increase our conspicuity for metastasis was to look at coronal imaging, and to scroll through. So like back and forth at one region instead of like scanning the entire liver with each scroll. So I thought, and this is a really, really impressive paper. And the presentation at the SAR was like phenomenal. Anyways,
cool that they tracked their eye movements.
They did a lot of things to track eye movements for what? Oh, the image navigation.
Tracked image navigation and eye movements, it says.
Yep.
Yeah, that's so cool.
Yep. And they also, they did that, and if they fed it to an AI algorithm that then looked at the different types and patterns of metastasis. And it was the AI algorithm that found that the peripheral lesions were often missed by general radiologists, and were often, the peripheral lesions were the most commonly missed lesions. Even though specialists had a higher detection rate, they also missed the peripheral lesion. So when you're looking at the liver, make sure to look at the edges because those are the areas that we often miss.
Right, but here, even knowing where the mets are, when you go
Oh,
back
yes,
to look, like,
yes.
you can't really.
Agree. In your case, it was just super hard. I mean, maybe there was something in segment 6, a little hypodense stuff on the coronal that I may have said something about, but the other ones where we saw perfusional wedge, the wedgy perfusional changes are not apparent.
I have a comment about the search pattern thing and also like missing the stuff in the periphery. There was a radiographics paper last year by Michael Hartzung where he was talking about search patterns, and there's something called like drilling and skrilling. Like basically there's certain organs that you can actually like pan across them in a few images, and others that are kind of deep organs or long organs that you have to drill through. And your field of view of your fovea of your eyeball is only a certain size. So you can actually only see a certain amount of things. And my impression from that was that like for the liver, you actually should scroll through it like 4 times, like for each sector of the liver, like the right posterior, right anterior, and then maybe the left lobe or whatever, but you can't just do like one scroll through the entire liver. The same way you can't look at like both kidneys at the same time or both lung bases at the same time. Your field of view is just not big enough to actually detect all the things, especially like the peripheral things.
Yeah, I agree with that. I like for the peritoneum, I chunk it into 4 quadrants. So for the liver, I don't chunk into 4 quadrants. I do more like lobe. Like I'll do a right lobe and then left lobe. But maybe my right lobe is still too big of a field of view.
Yeah, I'll have to like look back at what the size is, but it was kind of shocking because it was like, oh wait, we should be scrolling through this a lot more, definitely using liver windows. And then Victoria, what I like about your case is like, okay, there's the patchy enhancement because of the fatty infiltration, but like when you have perfusion abnormalities and you have some buildup, like those are 2 very important, like subtle but important signs that there could be an underlying lesion. And with such a big pancreatic mass, like level of suspicion should be really high. So yeah, I mean, I think like your case is really tricky. You can't see them well, but there are these secondary signs that we should be very attuned to.
Right, agree.
Cool.
Okay,
Thanks
my
for
turn.
sharing that paper, Nelly.
Yeah. Okay. This is a patient who, well, I'll withhold, let's say defecation problems. So this is the squeeze is normal. It's nice lift. And this is when the patient bears down. I'm not sure that my instructions were clear, but, and then this is when the patient defecates.
Oh, nice. Sorry.
So what do you think? Here, let me just.
Is there intussusception / prolapse?
Yes, so this is a prolapse. And so I do a physical exam on all the patients now because sometimes I think it's just a lot easier to make a diagnosis. So all of this tissue is rectal, like it's rectum that's coming out, prolapsing right there, this here. And it looks, and I was able to reproduce it on exam, but I'm going to give you a cartoon picture from Google.
Hey, while you're on this, can I ask you a question? When you say that that's rectal tissue there, is that also, would you also call that a rectocele, like an anterior rectocele?
Can I answer that after
Yes,
I show the picture? Okay.
Sure.
So this is what it looked like when I did the physical exam. So the because I wanted to see it because that he came in with the history of rectal prolapse, and so I wanted him to reproduce it for me, so he did. And so this is what it looked like. It was like prolapsing out from his anus, and so it's confirmed with physical exam, and that's what these tissues are right here. It's rectal prolapse right there. All of this tissue, it starts inside, right, and then it comes out. And then it comes out. And so you see that kind of layered pattern as it prolapses out. And this is the layering that you see on the cartoon picture.
So
here.
it's basically a like intussusception, rectal intussusception, but all the way through. I wish I could, if you, I'll try next meeting we have to bring my, to go through my laptop, and I'll show you the MR image. So if you do MR, you can actually see this correlate. It's the entire wall that invaginates and collapses.
Yes.
This is pretty amazing to see it on the
Defeco, yeah.
Yeah.
Yes, it was a great case. Go ahead.
Yeah, and then Aarti, the anterior rectocele would be where the anterior rectal will protrudes anteriorly to where you expect it to be. So that wouldn't be that.
Got it. So is intussusception and prolapse the same thing?
Prolapse is like once intussusception goes through the anal orifice, that's prolapse.
Yeah, so prolapse is outside. It's
Yeah.
outside the anus.
Correct.
Okay. But it's still, like,
Intussusception, because you can have a
technically
retrorectal intussusception that's inside. Like you can have a retrorectal, but it won't become prolapse until it's outside.
Got it. Very cool.
And this is different from descent. So with pelvic floor descent, you don't have tissue that's coming out, right? The whole floor is just saggy, and so then it descends. But prolapse, it comes out. And then rectocele, it goes forward or posterior, I guess. And if it does, and many patients will have rectoceles. The key for what determines if they're going to get surgical treatment versus kind of just, physical therapy, pelvic floor physical therapy, is the size. So the surgeons will only touch it if it comes out through the vagina. So if it just pushes on the vagina posteriorly, they don't touch it. That's just, it goes to physical therapy.
Cool. Just to clarify, if anybody out there in the interwebs was thinking about the anterior rectocele part, I was wondering if it was just not filling with contrast, but you could see like little bits of it. But I understand what you're saying now. Like it's not at all going forward. It's just basically it's intussuscepting.
And so it's prolapsing out. And so prolapse they can address surgically. Sorry, I meant to mention, like, pelvic descent, that's not correctable surgically. So those two entities have different treatment managements.
All right, so this is also not not an eye test. You can see a huge vaginal mass. kind of heterogeneous again, kind of slightly hyperintense, but also kind of grayish. You can see a little of you know, T1 hyperintense blood products. Here it is on T2. And wait, let me stop sharing for 1 second so I can pull up the contrast. Otherwise, I'm just gonna de-identify the patient. I've never like disliked PACS as much as I dislike this PACS. There's so many things that are not convenient. Anyway, you can see here, it's kind of, again, we see blood products, very heterogeneous enhancement. So you really obviously can't make the diagnosis just based on imaging, but it's just a large vaginal mass. This was Ewing sarcoma.
Wow.
From vagina, primary.
Wow.
Isn't that crazy? This is just, you know, again, it's
Can you
not
show the diffusion?
okay, hold on.
It's interesting. It doesn't even look that aggressive, like as far as necrosis.
Right. No diffusion. Why, I don't know, but no diffusion. Sorry. So there's no diffusion. I don't, yeah, no, this looks really pretty remarkable. But you know,
I mean, it's a good reminder that there's extra osseous Ewings. Again, this would be a biopsy case. But just, I was thinking it might be more on the benign mesenchymal spectrum, just because it didn't look as aggressive as like a sarcoma.
right. But you know, but again, like, you know, sometimes, you know, think, and we all know that, right? Things can look pretty aggressive and it ends up being something benign, or sometimes things look not terribly aggressive and come out to be malignant. So
I feel like the T2 is so helpful, and it's easily becoming one of my favorite sequences, that evil gray.
right, and then the fact that it has blood products, of course. That's all I got.
This patient, this was an outside study. Patient had a prior hysterectomy, and then this was reported by outside. We didn't reread it here, but we have MR. There was a mass, a pelvic mass here. Prior hysterectomy. So we got an MR for further evaluation of this mass. So we got a MR, and there's the mass that was reported on CT, prior hysterectomy, as I mentioned. What are your thoughts?
Very T2 dark, like could there be a retained fibroid?
Here's your T1.
Ooh,
Something bloody.
yeah, there's like blood. Did they do a supracervical hysterectomy or a
Let me
partial
give you the
hysterectomy?
T2. To me, what do you think?
No, looks.
It looks like part of the uterus is still there. Like there's still part of the endometrial cavity with blood in it.
I like more the retained fibroid situation.
I gave you T1 already. Let me give you post contrast. So here's post. Let me give you subtraction because that's helpful, I think.
Yeah, exactly.
Here's a subtraction.
But it's normal. It looks normal.
Okay, what else do you guys want to help you?
Axial.
Axials, yep, axials. Here's, I guess.
Is it a rudimentary horn with functional endometrial tissue that was left behind?
Do you have
Here's
subtractions?
high field, yes, diffusion. Diffusion is,
And subtractions also.
okay. So here is our high B value. And then here is our ADC. Let me scroll them together. So the T1 bright stuff is restricting right there.
Right. As we
And
expect.
then, yep, as we expect. And then this is the other parts of it. So let me show you the T2 again. So we can, right there. Okay, anything else that you guys want?
Sorry, can you scroll like
Wait, can we see
enlarge the
subtractions?
T2 and scroll through?
Oh yes, I'm sorry, subtractions. So subtractions here.
So it is enhancing, so it's not some sort of blood product.
There's blood products central.
Yeah, the blood product, but I'm saying like the
Peripherally.
rest of it is not just some weird blood hematoma or anything like that.
Wait, Nelly, can you go through the high-res T2 axial again?
Yes. High res T2 is right here.
We're dying to know what this is.
Yes.
I don't know, the periphery looks weird. But it's really dark.
All right, I will, we were struggling too, and just throwing different things out there. So this turned out to be an endometriotic cyst.
Damn. Wait, how? It was enhancing.
It wasn't actually, it may, I don't know if it's a fake out or kind of a, there's co-registration or misregistration because it's kind of more along the margins. But it was just that, that's it. And this is the T1 hyperintensity, the whole thing. That's what the pathology reported was. Crazy, right? Endometriotic cyst, 8
That's
centimeters in
crazy.
greatest dimension. And then there's endometriosis, superficial and deep endo elsewhere too.
I was gonna ask, like, when they did the hysterectomy, was there endometriosis,
It was done
adenocarcinoma?
remotely, like
Got it.
priors, yeah. So the patient presented, and MR was done for evaluation of that pelvic mass that we saw that was seen on.
Wait, can you show the
CT.
post contrast again?
Yeah. So here is, let me see if I can. It's a pre. Here's the arterial. Here's the subtraction of the arterial. Here's 60 seconds. And then here's a subtraction of that 60
There
seconds.
is definitely enhancement peripherally. I am in defense of Victoria's, because I think like, look at that. There's on the subtraction, and even when you compare pre and post, there's definitely enhancement.
I mean, the blood part doesn't enhance, but this gray stuff.
Yeah, this stuff, the peripheral
Yeah.
stuff, right there.
Maybe I'm-
And I'm not saying that still, it's not an endometriosis cyst, but this kind of, Nelly, gets back to remember those cases you showed where there was like an enhancing component and we hedged on malignancy and it turned out to be benign. But that whole rind there is enhancing.
Could it be kind of, this kind of blood product that's pushing on it and then causing not so much an enhancement, but compressive enhancement? Like it's just
No,
massive
not that
factors.
not that little part, the whole rest of it, that whole rind, like there's like a 2 centimeter rind.
Yeah.
This rind,
Like
you're
the
talking
blood
about this
flow.
No,
rind
not
here,
the
right?
rind. No,
Oh no, not that tiny little sliver, the whole large part around it.
Oh, this stuff here?
Yes.
Okay.
That's enhancing. So unless it's like in a piece of leftover uterus, like why is that enhancing?
Well, I don't know what the answer is. And I think whether it's enhancing or not, maybe there might be disagreement. But having said that, I don't know. Like this low level enhancement is what you're saying. Yeah.
Yes.
Yeah, I don't know, but surgical pathology is all endometriotic cyst. So the teaching point is just how weird and complex endometriotic cyst can look, and it can mimic really bizarre, findings. Yeah, and sometimes you just don't know.
Okay, this patient, fairly young, came in for abdominal pain, and incidentally, we saw something in the pelvis.
How old is she?
25. Do you see anything in
So
the comments?
diagnosis is wide and includes benign malignancy allergies.
Yeah.
Wait, what'd you say?
Well, there's a left ovarian kind of heterogeneous enhancing, like yeah.
Exactly.
There's like a
Okay.
enhancing something in there, or I think it's
Yeah.
enhancing. We don't have
I don't know if
non-con,
it's
but
anything, it's hyperdense.
yes, agree. That's right. We don't have non-con, so
Yeah, so just out of
pelvic
curiosity,
ultrasound.
young patient, we have this lesion. We don't know if it's enhancing. What would you guys recommend? Like further workup now?
pelvic
Follow up
ultrasound
Pelvic ultrasound, yeah.
pelvic ultrasound now or later?
now. I mean, what do you mean later? Like how much later?
Well, sometimes you're like, oh, it could be hemorrhagic cyst, and let's recommend it in 6 weeks or something. See if it resolves.
I would just get it now. It
They
doesn't look
did
like a
get that
hemorrhagic cyst to
The
me.
pelvic ultrasound. I'm not going to show it because of the stamping of the thing, but I will tell
Sure.
you, the pelvic ultrasound, it persisted, it looked solid, and it looked like it had vascularity within it. So we ended up getting an MR. Here's the MR. Here's some images from the MR. So here's the T2. It's actually pretty T2 bright. Here's the pre. The arterial, very avidly enhancing. Venous, it still persists. Delayed, it's kind of a little bit washing out, but you can see it's an enhancing solid mass. And
It has like a little capsule.
yeah,
Yeah.
I'm going to tell you that's not specific, but there is something suggestive about this lesion. So one, it's avidly enhancing. And then to show you these side by side. So I'm going to go to the in and outs.
Artie, you're cutting off like the lateral, left lateral.
Yeah. Sorry. I'm trying to squeeze it in. Okay. Okay. Can you see the in and out now? Okay. In phase,
So
out of phase.
So there's intralesional fat.
There is intralesional fat. So normally when we think about intralesional fat, not a lot of ovarian tumors do that. Dermoids can do it because they can have both bulk and intravoxel fat, but you can see there's no bulk fat here on this, even on the CT. So, you know, is it a dermoid with intralesional fat, but avidly enhancing? I will tell you in the end, this was not a dermoid. And my very smart colleague Amir brought up a possibility that this turned out to be. So do you guys know about any solid enhancing ovarian masses that have intravoxel fat or microscopic fat?
Well, Brenner, I was thinking Brenner until we got to the fat part.
Yes, good thought. So Brenner solid epithelial tumors, they overlap with like fibroethecomas. It was not Brenner or fibroethecoma, but like in that.
And the T2 is not like, I mean, if the T2 is not supporting the comas spectrum.
Right. It's actually T2 bright.
Yeah.
Perfect. Exactly. So T2 bright.
And the enhancement pattern too. I mean, they don't
Pretty
like,
avidly
avidly
enhancing.
enhance like this one does.
Yeah. So this turned out to be a steroid cell tumor, which is one of the sex cord stromal tumors.
Him.
And my colleague called it prospectively.
Wow.
So, yeah, hold on. I'm just going to stop sharing for a sec so I can bring up a couple of things about steroid tumors. Okay, so first of all, just radiopedia ovarian tumors, just to overview, most ovarian tumors are going to be epithelial tumors, including serous and mucinous. So that's going to be like 80% of all tumors. And then there's lots of like other rarer variants. And then we've got solid tumors, which actually, okay, we've got germ cell tumors, 20%. So those are going to be your teratoma and your dermoid, struma ovary, etc. And then we've got these sex cord stromal tumors, which include fibroma, fibroethecoma. This is going to be in the solid differential category along with Brenner tumors. Interestingly, even in radiopedia, they do not list the steroid tumor. So when my colleague brought up steroid tumor, we were all like, what's a steroid tumor? What is this? So I will show you a paper. This is about steroid cell. In this particular case, the patient had von Hippel-Lindau, but in general, steroid cell tumors, I will show you, he showed us this case and was like, look, it looks just like my tumor. It's pretty avidly enhancing and it has intravoxel fat in it. So in this case, the patient had hirsutism and virilization. And whenever you have both, this virilization as well as a lipid-containing tumor, you should start thinking about sex cord stromal tumors, including the steroid cell tumor. So I don't think, it's a difficult one to call prospectively. It's one of the subtypes of sex cord stromal tumors. About 50% will be androgen producing, so it'll make testosterone, produce virilization. 20% will make estrogen, and another 10% will make cortisol and lead to Cushing syndrome. So I guess the thing is, like, you have to look at their clinical thing, and then if they happen to have intracellular lipid, because steroids are lipids, you can bring up the steroid cell tumor.
Did the patient have symptoms?
No, so in this case, that would have been really awesome. But this patient, completely asymptomatic, they came in for like abdominal pain. They did not have any hormone abnormality, and it turned out to be a steroid cell tumor. But the cool thing was, like, he found this one in the literature and was like, oh, it looks just like mine. Like, it's enhancing. It's got the microscopic fat. Let's bring it up. And that's what it turned out to be.
That's amazing.
That's awesome. I bet Cookie would love it for her cookie jar.
Well, tell Cookie to watch this episode. She apparently has.
She does watch these episodes, and well,
for those of you out there, he's been sending us feedback via email, which I love. And she's like, oh, I agree or I disagree. And it's awesome to get her input. This so this was a steroid cell tumor, and I have one more companion case. Let me just quick one. So this is just another pelvic mass case. This patient was actually quite young, like 18. So we thought, cervix, uterus, ovary, and then we thought the other ovary was over here. And then we've got this huge pelvic mass. They have no prior surgeries. Would you call this an ovarian mass? Would you call it a pelvic inclusion cyst? A lymphangioma? It had no.
Can you show the sagittal?
Okay, wait, let me just show you. This is the, and the relationship to the ovaries is like one ovary is here, so it's like touching it, and one ovary is here.
Cis adenoma is going to have this appearance. Serous adenomas.
This is what it looked like. And Nelly, you got it. So this was resected and turned out to be a 15-centimeter serous adenoma of the left ovary. And the cool thing in this young patient, very young patient, was they were able to, it was basically para-ovarian, so they were able to save the ovary. They were not able to save this left fallopian tube, but they were able to preserve the ovary. So fertility preserved. They removed this benign serous adenoma. It had no malignant components or even dysplastic components. Lost the tube on this left side, but yeah. So this is interesting to think about, these very simple appearing big cysts are still in the spectrum of ovarian lesions. This is an epithelial one. It was a low grade one. This was like the benign version. In the notes, they said they weren't going to follow up, like do any follow up on this because it was a completely benign lesion. So, but yeah. When we
and
first
do they
saw it,
have to be resected? Like, I feel like the imaging features for serous adenomas are pretty.
But isn't serous adenoma like a precursor to
Yeah, they have to
eventually a serous adenocarcinoma? And this patient's like 18, like you want to follow this up forever,
No, they has to come out.
And it could be a lead point for torsion for that ovary too, I guess. So yeah, anyway, just the more benign version. If this was like a postmenopausal patient and it was much smaller, those are the ones I think we like to follow. Okay.